Glaucoma is defined as increased intraocular pressure from aqueous humor within the system. Open-angle glaucoma is caused by decreased flow through the trabecular meshwork and canal of Schlemm, and this can be caused by a buildup of a number of potential culprits, including red blood cells, white blood cells, or just retinal debris. Chronic closed-angle glaucoma is caused when the angle between the iris and the cornea blocks the flow of aqueous humor. This can happen in a number of different ways, including the lens moving forward against the iris or proliferation of blood vessels in the iris. Now, the most important thing to know about glaucoma for step 1 is that chronic glaucoma, whether closed or open angle, is associated with gradual loss of peripheral vision. Right? Gradual loss of peripheral vision. And this is for chronic glaucoma. Because it's gradual, you can also think of it as being silent. Most people don't even know they have it until a physician screens them for it using a visual acuity exam. This, however, is not chronic glaucoma. This is something entirely different. This is acute closed-angle glaucoma, and this is sudden onset, and it is very painful. It is obvious that something is wrong with this eye. A sample question on the USMLE might say something like, a lady woke up with severe right eye pain, headache, decreased vision, and nausea. You measure the optic pressure and it's 70 millimeters mercury. You should know that acute glaucoma is an emergency. Another important thing you should remember is that epinephrine is useful in chronic glaucoma because it decreases the production of aqueous humor. However, it is very harmful in acute closed-angle glaucoma because it leads to mydriasis, which further closes the angle. So epinephrine in acute glaucoma is a no-go. Now, this is a disease that increases in prevalence with age, and that disease is cataracts. The lens, which is normally transparent, becomes opaque and visual acuity is reduced. Eventually, this will lead to blindness. In this picture, note the complete opacification of the lens as observed on a slit lamp exam. Now, sometimes it may even be more obvious, as seen in this photograph of a patient with a cataract that occurred secondary to trauma. You can clearly see the difference between the unaffected pupil and the one with cataracts. The pathogenesis is thought to be due to progressive oxidative damage to the lens, causing scarring and then healing by opacification. Risk factors for cataracts include age, smoking, alcohol, sunlight, and as in this case, trauma. If you see cataracts in children or young adults, you should suspect a congenital toxic metabolic cause like galactosemia or diabetes. Papilledema is a sign seen on opto exam of increased intracranial pressure. Essentially, when you look through a fundoscope, the optic disc margin is blurry, as you can see here. Increased intracranial pressure usually presents with headache, blurry vision, and cranial nerve 6 nerve palsy. But to establish the diagnosis, you must use fundoscopy. It is important to remember that papilledema is a sign that there is increased pressure in the brain, but it doesn't tell you anything about the diagnosis. For instance, a 26-year-old obese woman comes to you with headaches, nausea, vomiting, and visual changes. You look into her eyes and you see this. Her MRI has no abnormalities. What is the most likely diagnosis? The answer is pseudotumor cerebri, also known as idiopathic intracranial hypertension. This is usually seen in young obese women. It is increased intracranial pressure resulting from an unknown cause, and the main symptoms are headaches, nausea, and vomiting. The papilledema seen on exam is the clue that there is increased intracranial pressure. Of course, there would need to be an absence of some other cause after clinical tests to arrive at this diagnosis. As we discussed, there are 6 muscles that move the eye around and 3 cranial nerves innervating those muscles. Now, cranial nerve 3 innervates 4 of 6 muscles: the superior rectus, the inferior rectus, the medial rectus, and the levator palpebrae. Cranial nerve 4 only innervates 1, which is the superior oblique, and cranial nerve 6 also only innervates 1, which is the lateral rectus. What would a defect in cranial nerve 3 produce? This would give you a down and out eye because of the unopposed actions of the superior oblique and lateral rectus muscles. Also, there is ptosis due to lack of the levator palpebrae muscle innervation. Pupillary dilation and loss of accommodation due to the loss of parasympathetic drive would also occur. What would a cranial nerve 4 palsy produce? Well, since this nerve innervates the superior oblique muscle, which helps the eye look downward in the adducted position, the eye will be elevated and diplopia will result in a manner such that the visual fields are displaced both vertical and also tilted. As a compensation for this, the head will be tilted down toward the lesion and the chin will be tucked in. This action brings down the affected eye to produce a level field of vision. This is often a very good clue that you will see on a step 1 question. So moving on, what would a cranial nerve 6 palsy produce? Now once again, you have to first remember what muscle this nerve controls. In the case of cranial nerve 6, it is the lateral rectus. No lateral rectus means that the eye will deviate medially, causing a horizontal diplopia. These functions are important to remember not only for the test, but also for your third year, when you will be expected to pick up on these deficits on a physical exam. Actually, that is our next topic. But first, we will have a flash quiz. A patient walks into your office. He has extreme pain in his eye as well as vision loss that occurred rapidly. What drug should you definitely not use? I kind of really set you up for this one. You should not use epinephrine. This patient has acute closed-angle glaucoma. Epinephrine leads to mydriasis, and as we discussed, this will further close the angle and actually make the problem a lot worse. So we just discussed the number of cranial nerve deficits, and so now the question is, well, how do we actually test for these in some practical manner? So one option is to have the patient follow your finger as you make an H. And if you do this, you will notice a couple of things. And so in this example, we'll say this side is the nasal side and this side is the temporal side. And so this is the right side of this patient's eye that we're looking at. So what you'll find is that the inferior oblique is isolated when the eye is looking nasally and up. The superior oblique is isolated when the eye is looking nasally and down. The medial rectus is best tested when looking nasally, and the lateral rectus when looking temporally. The superior rectus is isolated when looking up, and the inferior rectus when looking down. And that makes sense. So, if a patient appeared with this deficit on testing, what cranial nerve would you say was responsible? I'll give you a second to check it out. This would be a cranial nerve 3 palsy. There are a few obvious clues here. First, upon forward gaze, the patient's left eye has the classic down and out, telltale sign of a cranial nerve 3 deficit. Secondly, the left eye is unable to move up and medially. Both of these movements require the superior and medial rectus, both of which are innervated by cranial nerve 3. Lastly, you should have noted that the pupil of the left eye is blown and does not constrict as the right eye does. This is actually a really good example of that too. Let's talk about pupillary control. There are two terms that are frequently confused. Pupillary constriction, also known as miosis, seen here, and dilation, also known as mydriasis. Now, one way to remember this is that the D in dilation is also in mydriasis. Pupils constrict due to parasympathetic tone provided by cranial nerve 3 through the Edinger-Westphal nucleus. Pupils dilate due to primary neurons in the hypothalamus, which synapse in the lateral horn. Next, sympathetic tone is provided by the vagus through T1 preganglionic nerves. This leads to the superior cervical ganglion, to a postganglionic sympathetic nerve, and eventually the long ciliary nerve. The pupillary light reflex is much faster than actual visual processing. Light from the retina, so we have light coming in here. Light from the retina will go to the pretectal nucleus, will synapse and go to the Edinger-Westphal nucleus, which is bilaterally innervated. From there, you get parasympathetic drive back out to both pupils, and thus a lesion of the optic nerve does not stop a bilateral reflex. This consensual response is due to bilateral innervation of the Edinger-Westphal nucleus. When it comes to pupillary reflexes, you get one eye in, two eyes out. The only time that you will not get a bilateral reflex response is if the parasympathetic portion of the efferent nerve, cranial nerve 3, is damaged. A Marcus gun pupil is seen when the retina or the optic nerve is damaged, as in multiple sclerosis. Because there is decreased light input, the pupils do not constrict as much when light is shone into the affected eye. This is called the swinging flashlight test. When you shine the light into the non-affected eye, you produce a direct pupillary constriction in both eyes. However, when immediately swinging the flashlight to the other affected eye, there is less light perceived and the pupils will actually dilate relative to where they were. As we've discussed, there are two major functions of cranial nerve 3, controlling most extraocular muscles and parasympathetic output. Now, if you were to take the nerve and you were to cut it transversely, you would get a picture seen here. The parasympathetic output fibers compose the outer rim, and the output fibers to the ocular motors are more embedded. Thus, the parasympathetic fibers are most affected by compression. And you can see this is just pretty obvious, like mechanophysics. The extraocular muscle output is most affected by metabolic and ischemic causes like diabetes and hypertension because of decreased diffusion of nutrients from the blood vessels to the interior. Basically, you can think of it this way. All of the nutrients are readily available to the inner fibers when things are going well. But if the blood supply is cut short or there aren't enough nutrients in the blood, by the time it gets to the inner fibers, there won't be anything left. Sort of like the last people to arrive at a lunch talk. Alright, it is time for another flash quiz. A colleague is telling you about one of his patients who came in with an eye that looks down and out. Without further information, what is the most likely cranial nerve deficit? This is likely to be a cranial nerve 3 deficit. As we've discussed, down and out is a phrase commonly used to describe the phenotype of the affected eye in a cranial nerve 3 lesion.